time. So you are all here joining us to discover how chronic care management can increase your revenue. And this is a discussion with ChronicCareIQ. They are here as our panelists today, and we'll get those intros underway in a second. Let's take a look at that next slide. There we are. All right. So what's on tap? We're going to quickly talk about what Chronic Care IQ is. We're going to also touch on what Spruce is for those folks who are new to us today. What is CCM? What is that acronym? If you don't know it, we're going to cover it. What is RPM? Same on that front. How can you leverage your existing systems to make all of what we talk about today happen for you? We're going to touch on automation and time tracking and tapping into detailed accounting of care plans and patient adherence. I think why a lot of you are here today is to find out more about reimbursement and how you can ultimately get paid for the work you're probably already doing. So we're going to cover a lot of great content today. I want to tell you that the chat feature is disabled at the bottom of the screen, but please use the Q&A function to drop any questions you have in for the team. We will answer anything that is relevant to the topic and the slide at hand in real time, and we'll save all the others for the end. So as you think of those questions, drop them in because we are here to answer them. This session is also being recorded. So if for some reason you need to drop off, you can't stay with us the whole time, we will send the link out later today so you can get back to the parts you may have missed or even revisit things that were of particular interest to you. Next slide, please. All right, so just in case you aren't already completely aware of what we're covering, we're going to be talking about chronic care management and remote patient monitoring today. That's a tongue teaser. Whether you currently care for those chronic care patients or you've just been thinking about starting, we're going to cover how to get reimbursed for that work that you're doing. And it will be, I think, very straightforward, a very candid discussion around really how easy it is today for healthcare providers to just kind of keep better tabs on their patients with chronic illness. It's both for your own needs, you can improve those quality scores and such, but it's also an incredible patient experience. So we're going to cover that today and more. I'm going to pass the baton to Jess so she can quickly tell you about what Spruce is. And as an intro, Jess heads up sales at Spruce Health. She's been with us for, I want to say now 9 years. She is an expert. And I'm going to let her touch on that, and then we'll intro our other panelists today. Jess?
Hi, everyone. Welcome. I think we have a bunch of customers, so welcome. Thanks for attending. And we may have some people that are new to Spruce. So for those that don't know what Spruce Health is, we have a company that's been around for 10 years helping with patient communications. And we do everything from your in-office phone system to a virtual phone on your cell phone, texting, telemedicine, fax, and team collaboration around all of that. And it's all documented within Spruce. And so that's what we're here for. We work across all different specialties, and we're here to help you just communicate better with your patients. And we offer a free trial at sprucehealth.com so you can test it out. And we'll be here for questions about Spruce at the end as well.
Awesome. All right, let's see what's on tap next. Good. We're going to get into the meat of this. And with that, I'm going to let Justin Barnes and Matt Ethington intro themselves because they know themselves best. And I'm going to dip back and take my video off. But just sit back and relax and ask all those questions that you've got because we're here to answer them. Thanks, Justin. Thanks, Matt.
Thank you, guys. Appreciate it, Carrie. Thank you so much, everybody, for joining us today. I'm grateful to be here and very excited for the conversation. So I think the most relevant piece of my background, and certainly for the providers on the line right now, is I've been working since 2005 on Capitol Hill, looking out over improving reimbursement rates. So we were very successful staving off the reimbursement cuts in the late 2000s and then even through 2010 all the way through 2020 and 2021. But now, as you've seen, these reimbursement cuts for fee-for-service are well underway. And so that's why it's a very timely conversation today to find ways to augment that. And through those years, we also were creating value-based care models across the board for all the different specialties. And now many of you get to participate in those. Either you have in the past or hopefully you will in the future. But it really comes down to successfully navigating your practice and your care strategy through the future of healthcare. And that will, very simply translate into chronic care management, into remote patient monitoring and components like that. So again, very excited for the opportunity today. And we will be sharing all these slides with everybody. So no worries about that. So I wrote a piece last month that was published and it really looked out, when I was looking out over 2024 and asked for, where do I see healthcare evolving and how do I see it evolving? I got excited around these types of models. I know it can be daunting and it can be stressful at times, but it is important to begin to look out, if you haven't already, look at different types of value-based care models that are available to you. Many are available to you through CMS, but then also some of your private payers are offering them as well. But it's really important to begin to augment these cuts that have come in from fee-for-service with value-based care types of models. And again, very simply, that can be chronic care management, RPM, TCM. There's lots of different codes out there, and Matt's going to touch on those. But it is an exciting time. You start to think about the new reimbursements that can come in. On a daily basis, I work with practices that see anywhere from, on the low side with specialists, maybe 5 to 7, 8% increase from the reimbursement, all the way up to 30 to 40% increase in reimbursement or higher. So it's significant money. It's not just, little nickels and dimes here and there. It's significant. So hopefully, you like what you see here today. You want to ask more questions. We'll certainly leave time for Q&A at the end. But I really do see 2024 as a tipping point. We're going to have more care providers participating in these programs across the board than ever before, more patients being monitored, better outcomes than we've ever seen before as we get better as a country, and certainly as we get better as a government, looking to how to enable these types of programs and incentivize them. But we've really hit the tipping point. So I think it's really exciting from that component. Then also, to kind of back that up, our friends over at Sage Growth Partners came up with a study late last year with significant, increases across the board. So 94% of respondents talked about how RPM, remote patient monitoring, has improved their outcomes. And you're going to hear some of this cool stuff from Matt coming up, but that's significant. 73% saw their positive ROI from that. So, from those increases in patient outcomes, the money follows suit, which is exciting to see. And then also 94% of their CCM ROI came from additional revenue. So it's very strong numbers. And you're seeing patient engagement numbers anywhere total patient basis, anywhere from 70 to 95, 98% engagement electronically with their patients, no matter what type of populations they are. And again, these are chronically ill. So it's significant to the patient, a better quality of life. And Matt's going to hit on that. Matt actually started off, talk about this as a patient for these very reasons, right? How important it is. So there's not a practice that I touch that has not seen a significant increase in reimbursement, unnecessary hospital admissions or readmissions, improved patient outcomes, significant ROI. The ROI numbers, and Matt will touch on this, I'm sure, a little bit, 2,000, 5,000, 7,000% ROI, because these systems don't cost a lot to get started with, but the money that comes behind them is significant. So look forward to the conversation. Again, we'll have plenty of time for Q&A afterwards, and I'll turn it over to Matt. Matt, I'll drive your slides. So feel free, just let me know next slide, please, and I'll go ahead and drive them. Thank you very much.
Yeah, thanks, Justin. I'm especially excited to be here because I'm a patient. I'll tell you about that in a second. But when I became a patient, I realized it was almost impossible to stay on the same page as my doctor. So when Spruce invited us to talk about that, I was so excited because I tell everyone healthcare is communication. You can take what's in every pharmacy on the corner, and you can take all the procedures at all the hospitals, and they change, right? The procedures that are available, they get more and more complex. The drugs that are out there become, completely get new ones, and old ones go away. But what does not change is that healthcare is a trained individual providing care to someone in need. And at the core of that is communication. And it does seem to me, and I'm sure it seems to you, that we're a little bit behind in communication. The reason I know all this is at the age of 30, it was now 20 some years ago, I found myself in the hospital, in the emergency room. I was told that I was days and maybe hours away from being in a coma, and that I had type 1 diabetes, right? I knew that I was thirsty and something was wrong, and I knew that I was, losing weight, but I just kind of thought it would go away until it didn't. And I left the hospital with 2 prescriptions and a pep talk, right? And the instructions, you need to find a doctor. I called the American Diabetes Association and was told that I could practice giving myself shots by using an orange. And so there's a lot that happens. I was a pretty successful guy, enjoying my technology career. And so I found a doctor, and then all of a sudden type 1 diabetes is the kind that you have to give yourself shots. And if you give yourself too much, you can die in a short period of time. And if you don't give yourself enough, diabetes is a leading cause of amputation, blindness, loss of mobility, loss of financial independence, and bankruptcy. So I've had to manage a disease that has to be managed very aggressively. And just working in healthcare, I decided to switch working in technology, I decided to switch my career specifically to medical technology. And this was in 2000. Before smartphones, before a lot of buildings even had internet access. So I've worked with over 1,000 small practices. It's where my heart is. I see how hard everybody works, all the things they try to put together to make something happen. And a doctor at UPenn in 2014 suggested to me, like, Matt, you should do something for heart failure patients. And that's what started ChronicCareIQ. So they're revolving doors. So they're practically always in trouble. And it's because we don't know enough about them. So we really decided to focus on, well, if I had more information about those patients, I could do something about them. If we had more communication, we could do something about them. And then in 2015, they came out with reimbursements. And so I will tell you that it's not, if you're going to do participate in care management reimbursements or remote monitoring reimbursements, it's when. Medicare, an undersecretary of Health and Human Services, whose office isn't here from me, said that chronic diseases don't just break the bank, they break the US currency. Currently, 7 out of 10 deaths are due to mostly non-lethal and manageable chronic diseases. They're just not managed. And the money we expend on them is exorbitant. 99% of the checks that Medicare writes are on behalf of chronic patients, and it represents 93% of the total. If you take this money just spent on chronic disease, it's equivalent to 18% of our gross domestic product. So, and that's Medicare, right? So we all know the boomer population, the aging population, but the net is we're the fattest, we're the least active, we eat the most processed food, and than we've ever been. And that adds up to conditions that will get worse if they're not managed. But what we've shown and what studies have shown is that if you can keep those diseases managed, they don't need to have a long-term effect. They don't have a long-term effect on your outcomes and your expenditures. So when we look at chronic care management, Medicare is spending a fortune on these codes. We'll go into them in just a little bit, but there was one code for $42 in 2015. Today, there are 25. And they're in 8 different categories: primary care, specialty care, behavioral health, respiratory care, chronic pain management, even physical therapy. So there's a lot of reimbursements, and the vast majority of them pay for the non-face-to-face clinical activity that doctors and their staff perform for patients. Non-face-to-face activity, right? So it's not just we're going to wait for the patient to come to the office when they're sick. We're going to engage those patients before the sick get sicker. And the problem is so big, you've already seen those numbers, 86% of US healthcare costs overall. 10,000 patients a day will still be turning 65, are entering the Medicare rolls for the next 8 years. And some derivative of that will be turning 75 for the next 18 years. So Medicare's known this problem was coming, and that's why they're throwing so much money about it. And it's not necessarily, do doctors know what to do about chronic disease? They do, but they don't know when. Because our traditional care setup of we're going to have an office, a brick and mortar, and wait for patients to come in for scheduled visits, and we're going to train them on how to care for themselves or train them to know when they should care for themselves or when they should reach out, it hasn't worked. I think about every other aspect of our life. We even have doorbells that tell us who's at the front door, but we've got fire alarms, we've got thermostats, we have check engine lights, we have you name it, right? We have all of these things that help us manage complex things in our lives. Your phone's going to tell you when your bank account balance is too low. Your credit card balance is going to call your credit card companies and tell you when your balance is too high. But our doctors don't have anything about us to know whether or not we need help. And we set out to change that. And we say this all the time, doctors know what to do. The challenge is we don't have systems that tell them when. So if you could go to the next slide, Justin, I'll give you some key tips about chronic care management and the things that we think you need to do. You don't have to pick our system. Like Justin said, I think you should look across the board, but I'll show you, talk about a little bit what you need to do, regardless of whose systems you do. It's like, so why do the sick keep getting sicker? It's because they're invisible. I mean, who hasn't left the doctor's office motivated to make changes, right? So if it's being overweight, for example, I know that's one we struggle with at our house. I'm like, well, I'm going to start eating salad. I'm going to go for a walk and my meals are going to be a little healthier. And then I get home and it's late and I had an issue at work and it's kind of rainy outside and my son made a D on his algebra test and we don't have any lettuce in the house. Like everything's out the window. We'll do it tomorrow. We'll do it the next day. We'll do it to the next day. And eventually we go back to our habits. So it's really hard to know how to manage yourself between visits if you're not communicating back and forth with your doctor, right? You become invisible to your doctors or to your hospitals the day that you leave. The challenge is chronic diseases are medical conditions by definition that can't be cured, so they have to be controlled. So even if you can mitigate your type 2 diabetes to the point that you don't have symptoms, you still have it. You're just non-symptomatic. Even when you get your blood pressure under control, it's going to come back if you don't keep managing it. So the idea here is like if a doctor knew when a patient was starting to get off course, then they could fix it early on when the patient wasn't so far off course. But if I don't see that patient for 6 months and their blood sugar's been 270 every morning, it's too late, right? They've already damaged themselves. They've already had significant disease progression. So what we talk about is we have to make our patients not invisible. We have to collect data. And when we collect data, we can see who these red patients are that need attention, and we can see who these yellow patients are that need encouragement. If we'll go to the next slide, Justin. So that's what Chronic Care IQ tries to do. And this is how I think this is the first and most important thing you can do in a care management setting. Regardless if it's remote monitoring, if it's principal care management, which is like CCM for specialists, or if it's chronic pain management, the best thing that you can do is get visibility from your patients. So the way that you do that is by asking them questions. So that what Chronic Care IQ does is it sits on top of the electronic medical record and it might say, okay, Mrs. Johnson has stage 2 heart failure, diabetes, depression, and takes 7 or 8 medications. Well, we definitely want that blood pressure periodically. We want the glucose or the weight if they're a heart failure patient daily, but we don't just want the vitals. I want to know, are you short of breath today? Is it better or worse or about the same as it was yesterday? And I want to be able to ask you these questions and get these answers in a way that's really easy for you. Because if you're a patient, these are elective programs. If the patient says, I'm not doing this, I'm not answering 62 questions every day, and then they can stop participating. And if they stop participating, all of your practice's efforts are for naught, because they are patients consent to this. So they have to understand value. So you have to engage them personally at a level that they feel like they're getting value. And when your system, what technology can do today is it can look at the patient's electronic medical record and it can ask for symptoms specific to that patient. Have you seen any new doctors or started any new medications? When was the last time you were dizzy when you stood up? So you have patients that have multiple comorbidities, and this surprised everybody when we started, but it never surprised me. 87% of patients that start answering those questions will still be answering them a year later because their health is a concern, and you're constantly, at least especially for type 1 diabetes, but patients that have had heart failure, patients that have been hospitalized, patients whose quality of life is affected, especially our elderly, they feel that. And to have that security of knowing that the trained, sweet doctor that gave up their entire 20s is checking in on me, it is hugely rewarding. It will settle them. And so as a result, you see inbound phone calls reduce, et cetera. But the most important thing is engage those patients. And why? Because care for patients is communication. So if you're engaging them, then when their responses come in, right? So I guess the first thing, you can't do that on a one-to-one basis, right? You have to have a system that's going to look at those patients and engage them for you. And then it's going to take those responses. If you'll go to the next page, Justin, then if you'll want a platform that can look at those responses, compare them to what they were yesterday, what they were last week, maybe what they were last month or the year before last. And even in the case of Spruce, how many times have they called us this month? Right? Think about that for a second. Every health system in America has call data about their patients. But how many of them know, hey, this patient, we haven't heard from them in 5 months, and now we've got 4 calls in the last 2 weeks. That's a rising risk patient. So when you have a platform like a Chronic Care IQ and a Spruce, we're looking at different measures that aren't traditional to say, hey, something's happening here. Maybe someone should call that patient and get them enrolled in a monitoring program. We have 600 different clinical monitoring protocols that attach themselves to patients if there's a concern. And then you take those responses and you collate them on a color-coded dashboard, and it will work out like, hey, out of your 200, 150, 400, in some cases 12,000 patients that are enrolled, here are the ones that probably need some attention. You're not providing care. The systems aren't providing care. The systems are dialing your team into the ones that probably need some attention. So that's the first thing, is how do I get dialed into my patients where they see enough value that they stay involved? Because if they don't stay involved, then there's no such thing as a chronic care management program. If they do stay involved, you can deliver that care that your clinicians are trained to do. So having that situational awareness is important. It improves outcomes. It's why patients do it. And checking that dashboard generates 30 seconds a day on a 20-day month. That's 10 minutes. Remember, the care management reimbursements are based on time. How much time? The first increment of reimbursement starts at 20 minutes and it pays $64. So do that math in your head. $192 an hour is, if you could monetize 20-minute increments perfectly, $192 an hour is what Medicare and some commercials are willing to pay you to keep patients out of the hospital. It's an extravagant reimbursement. The trouble is, it's death by 1,000 cuts if you don't have the right type of system. So patient engagement is first. The second one, if you'll go to the next page, the second one is you've got to count up time, right? And how do you do that, right? So I heard somebody ask, can I do it with my EHR, different things? There's lots of ways we can engage with anyone. There's tons of resources on our website talk about how to do that. But where does your team spend their non-face-to-face time? If your MAs and your nurses are not, and your doctors are not in a room with a patient, where are they, right? They're on the phone about a patient, or they're in the chart about a patient, or they're hopefully texting a patient back. I love texting with my doctor. I hate talking to him on the phone. No offense, you're all really nice, but I got to press 6 buttons to get to someone. So you want to be able to communicate, but you've got to track all of that. So When you're using a Spruce, for example, and it took maybe 3 minutes to search the chart and 6 minutes to craft a response to the patient, that's 9 minutes. If you've monitored that patient through the dashboard and you've spent 9 minutes answering this thoughtful question for that patient, you're getting care back to them faster, you're improving their outcomes, but now you're only 1 minute away from $64. Now think about how many times your staff do that every single day. And you start to understand that, gosh, this $33 this month for this 2-provider practice, it's not really that unusual. And this practice, they're not special. I mean, they're special people, but these results aren't that extravagant. So you have to be able to add up the time. When you can add up all the time, what's being done in the chart, what's being communicated, not what's being communicated, but what kind of time is spent on the phone, what kind of time was spent in Chronic Care IQ, how much time did it take to craft that message and send it back. That is all non-face-to-face time. We've got tens of thousands of months of reimbursement. We've been doing this for 10 years. We've been audited, I don't know how many hundreds of times. When you're gathering up all of the time, it is an extravagant amount of time. We know from a 3-year retrospective study of Ascension data that 29.4% of the patients on Chronic Care IQ, or that Chronic Care IQ cohorts of patients had 29.4% fewer hospitalizations. It stands to reason, right? You know that, hey, this patient's heart failure is getting worse. Let's get on the phone. Maybe they haven't taken their diuretics in 4 days. Well, if you fix that now, if you fix the AFib problems now, so there's lots and lots going on there, and your team is already doing a lot of this work. When you add the monitoring on the front end, and not just, hey, we didn't get your blood pressure, but when was the last time you were dizzy, right? Those are the things that really keep patients engaged, because now they know that they're getting that care. When you soak it all up, when you put it all in pieces, then it begins to make sense. The third challenge, and we're not quite to the next slide yet, is you've got to make it easy for staff too, right? Staff are just as important as doctors. They've got to be able to get to it, make sense of it, understand what they need to know. And I'll go back to that first example. When you have a system that looks at these call durations, this level of communication, these call frequencies, and it can tell you, hey, this is unusual. Like these patients are communicating a lot more than normal. That empowers you with a tool then to say, hey, what's going on? Would you mind if we enrolled you in this monitoring program? That sounds like a concern. We just want to keep a little better tabs on it. So thinking about what we do have, what we're already using, and tracking all the systems that we already use to give us time to add on top of that monitoring makes a very, very revenue productive, cash flow positive organization. I know that this practice that we're looking at, I know we charge a flat fee of $500 per doctor per month. So it really, you see 3,300% ROI. Basically, that means they get $300 for every dollar they spend on us. So it isn't unusual to see people with a 10-to-1, 20-to-1 ROI because you're doing that much work. All right. So Justin, I'm going to talk too long if I'm not careful.
Well, no, I just want to fall back up here because you mentioned 33. That's $33,000. So this is a 2-doctor internal medicine practice. This is all live data that you pulled out of the system. So January, they brought an additional, again, 2 doctors, initial almost $34,000 of reimbursement to their practice. So it's significant. So,
well, I mean, it's not unusual when you think about
exactly.
where are your nurses? They're always on the phone. Right. So that's the other point I make. If your phone system, if it's not Spruce or it's not making you money because you're using it all the time, that's an antiquated model these days, right? Medicare's paying a fortune for that time. And if it can't tell you how much reimbursement you're due, then it's worth looking into because the money's significant. So here's the other thing. When I said earlier, it's not if, it's when. We started writing these codes in 2014 to track heart failure patients on their discharge from the hospital. So we have 500,000 lines of code. Every year since 2016 was the only year that they have not either added codes or increased the reimbursement. There was one lonely code for $42 in 2015. Today, there are 25 codes that pay you for your time. Some of them, yeah.
Oh, I just, someone had a good question that's relevant to this slide. So as you said, like we started with one code, and I can see on the slide, like every year, every other year, we're getting more. What do you see in 2025 and 2030? Like, what do you think the future of these codes? Or do you think we're going to get more? Do you think they're going to reduce it? What are you thinking? Or either of you?
Yeah, so Justin has quite a bit more experience at the policy level than I do. What I would say is that the RPM, like right now, Medicare's been really liberal. If you give a patient a blood pressure cuff, they're going to pay you $54 a month. If you get readings on 16 days, I think they'll start enforcing medical necessity. I think they'll start looking for labile hypertensives, and they won't just pay that every month for every patient. But these are the foundation of value-based care. So these reimbursements, I think, will continue. And for $192 an hour, gosh, if I could make $192 an hour on staff, there would not be any extra office space in Atlanta. But Justin, you should share your observations.
Yeah, I echo what you just said. I mean, these codes, they're gonna release new codes. They're gonna continue to hone them in, like you mentioned. But this is the foundation for where the future of healthcare is going. Certainly from a federal government, from CMS, Medicare, Medicaid. They're going to continue to invest in these programs. Unfortunately, we do see more and more fee-for-service cuts. That's been kind of hard-coded in there. I don't see any big changes to that. So this is the augmentation. This is where you augment. This is how, they might have a 3 or 4% cut with fee-for-service, but you're going to have a 5 to 10 to 15% increase in these type in care management codes and in value-based care types of codes. So you can make a lot more money. And that's actually been the case the last 10 years. However, it is difficult to navigate these. It can be daunting and certainly intimidating. But the fact that everybody's here today, you're starting to learn. These are very easy steps to get in there. And one question I'll leave to the end, Matt, that I want to follow up with is, I want you to walk through, not now, but what specialties do you see? Because these codes, I don't think those are in the slides here specifically, but I do want you at the end, let's touch on that, because we have lots of different, Spruce has a very broad customer base with lots of specialties. And so I want to also touch, as we close, on which specialties these are set for. But I see them, but in that regard, I see these expanding tremendously as well. So a lot of, covers dozens of specialties today, or dozens of specialties, but you're going to see more added on as we go on in 2025, 2026, and 2027 and beyond.
So a presentation that was made by an independent doctor of our platform showed a 29.8% reduction in readmission. So Medicare is not, if you're my age, I'm 53. When was the last time? When was the only time you have ever seen Medicare increase and add codes like this? Never.
Never.
Right? But the fact is, the average Medicare hospitalization today is between $14,000 and $15,000. Right? They're happy to pay you $64. In our case, the average is $103 a month. They can pay you to manage that patient for a decade just by preventing one hospitalization. The money in healthcare is with pharma and with the hospitals. It is not with the doctor's office. All of this mission is to put care back into the doctors. And instead of waiting for the sick to get sicker, the analogy is, in medicine today, we change the engine instead of changing the oil. So this pushes, let's get healthcare back to the doctors outside of the hospital instead of waiting for them to show up at the hospital with massive amounts of disease progression. And so it's easier, it's less expensive, it's certainly a better quality of life for the patient. That's why they're throwing money at it. They save a ton of money. So this is a shameless plug for us. Our clients, I think the biggest numbers that I should tell you about is our clients have enrolled over 140,000 patients. And like I said, we attach to themselves, we attach to the patient. based on the EHR, what their problem lists are, and it gets assigned a clinical protocol that then starts to percolate and say, hey, here's a question you should have here's a patient you should have a look at. And then even if the patient, their answers have all been great, it's incredibly rewarding, like through, a Spruce, to shoot them a text, like, hey, your numbers look great. They look great this week, right? That's encouragement. That's what really glues people, because a lot of these our doctors usually enroll the sickest. They start with the ones that they're especially concerned about first. And it's just a massive relief. It's a type of security they don't get elsewhere.
Why don't we cover the specialty, Matt? Why don't you cover also the broad specialties that you're aware of, that you've actually been personally able to manage?
Yeah, so internal medicine, primary care is now our largest segment. After that, it's cardiology, right? Their patients have high needs. They're highly motivated. Nephrology, anybody that's facing an advanced level of diagnostic care. So the surgery specialties, at least for us, they're pretty much out. Dermatology, there's a few dermatologic conditions that do get managed. But it won't fall into your ophthalmology, OBGYN for high risk pregnancy, but the commercials don't really cover it. So it's really the type of healthcare that's the domain of the elderly is the type that finds us. Pulmonology is big, chronic pain is big, nephrology. Yeah.
Question, I obviously am not practicing here and doing these codes and stuff. Is it only Medicare reimbursement?
No.
So,
And in
so
fact,
it's all, so you can see non-Medicare patients and still get these coding and reimbursement.
yeah, so yes.
Okay.
Yes. So it depends, right? There's 25 reimbursements.
Right. Yeah.
Blue
I
Cross.
just wanted to make sure it wasn't just a carve out into Medicare only. So
Right.
that answers that. Another question, or just another, I just wanted to kind of get people's bearings a little bit because they may get confused. So, you have chronic care management, and CCIQ is a company that helps you do that. I mean, you can see how confusing this is, how many different codes there are, what the different amounts per code are. I mean, it's overwhelming. And so there's companies out there that help you get chronic care management reimbursement. CCIQ is one of them that happens to also use Spruce's data to help you do that really efficiently. You could do this stuff on your own. However, as we've seen, it's complicated. So CCIQ helps you do this, and they help you doing this by getting into your EHR, by giving your patients an app that they can then fill out, what they're doing, remote patient monitoring, help assist in all those things. And they take all those things. You don't have to use them all, but take what you have and then help you get reimbursed for it. One of those things is taking the Spruce data and helping you get reimbursed for it. Another might be, what you're doing in the EHR, the app for the patient. So you can communicate multiple ways. You can call them through any phone system, or if you happen to use Spruce, it'll be documented. Or you can text them photos and have them text you photos of your remote patient monitoring stuff through Spruce or through another app. So because I saw a question come in about like, can you send a photo? Can the patient send a photo? So we're talking about multiple channels of caring for these patients, and then using a company like CCIQ to help
make
get
sense
that
of it
all
all
together. So sorry, just wanted to say that because I didn't want people to be confused on kind of what's what. Like Spruce is one way, but they also have an app that sends them questionnaires regularly. They can look at data from the EHR. So sorry to take that tangent, but
No,
yeah.
yes, I think that was super helpful. And actually, I've had a few folks ask me as well, if this is applicable to the behavioral health side of the house. And I know that it is. Can you quickly touch on that?
Yeah,
sure.
And specifically behavioral health, can be a lot of specialties. So what about counseling, psychology, and then, those two specialties, like non-MD reimbursement?
Okay. So, yes, right. To summarize, you need data from patients to manage them.
Okay.
So the platform asks questions that would be specific to those patients, looks at those answers to alert the clinician if there was something troubling so that they could get involved early. The reimbursements are based on the amount of time. So you want to soak up that time where it's taking place. And Spruce gives us a tremendous amount of data so we can calculate that time. And because we can not only quantify the time through Spruce, but we can also qualify who did it. We can assign the right reimbursement to the patient who maybe should have additional reimbursement or a different reimbursement because they're a Blue Cross patient that pays mostly for RPM, or they're going to pay CCM because they're Medicare Advantage plan, or they're a Medicare plan. So it's not just exactly can we bill, it's which one should we bill so that we get the optimal reimbursement and the optimal combinations of reimbursement instead of either overbilling or underbilling. Now, when it comes to behavioral health, there's a huge reimbursement for behavioral health. If you'd like to look it up on your own, it's called BHI. And when you do complex BHI, behavioral health integration, and you actually involve a psychiatrist, there's something called collaborative care management. So there's a BHI and a complex BHI, if you will. Behavioral health integration pays for 30 minutes of time, and that does include counseling. So it's everything from, it focuses a lot on addiction. They focus a lot on depression. They focus, in so many areas, right? It is a constant endeavor to be available to a patient when they need care. So sometimes patients get questions like, did anything trigger you today? How did you feel afterwards? If you know that a patient is driving by their old bar and their old hang at 5 o'clock or 5:15 every night when they get off work, it will push questions to those patients. And it would say, how was your day at work today? What are you looking forward to when you get home tonight? Is there anything XYZ? And so that enables them really to kind of keep tabs on those patients and sense when they're starting to stray. Here's a great one. Do you have addiction and brain diseases? They're the worst. They're the worst of the worst because you just feel so helpless. And it, so some of those patients sometimes feel like they're on fire. And the hardest part about being sick is not knowing when you're going to be well. So behavioral health patients, if they're experiencing breakthrough symptoms.
Well, here, Matt, the only thing from time, we probably got to keep on moving because we have a lot of questions coming in. These are great questions. So you want to quickly cover the case study. This is actually a mutual Spruce customer. As you've heard, we are fully integrated with Spruce, which is, the top communication platform in healthcare. But I'll just run through this really quickly so we can go to the next slide. But, tremendous ROI. Almost 19% Medicare reimbursement increase. Like I said, this is across other plans, but Medicare is certainly one of the leading payers for chronic care and RPM reimbursement. But also every month they're increasing their CCM enrollment by 6 to 8%, their patients. So that's a great success story in itself. And patient billability, 90%. So these patients are, they're going through the program, but also they do have chronic conditions, and so you are able to bill them. That's brings significant ROI. So yeah, this customer alone that we have in common with Spruce is a 4,000% ROI. So that's just, obviously very, very successful on all parts. And it's great to see this kind of patient engagement and success. So I think, Matt, you probably have one more slide here. Yeah, I think this just kind of closes out. I know we have a lot of questions coming in, so we'd love to hit some of those really quickly too.
Well, and it goes back to what I say, right? If you can engage your patients in a way that's meaningful to them, they will stick with you. They will feed you the data that you need to be able to keep them well. You're already doing all the work necessary to drive reimbursement. You just can't capture it because it's death by 1,000 cuts. So plug into the places where things are happening. Plug into the patients so that you know when they need you, right? That keeps them engaged. And then plug into the systems. Make it easy for the patients. Communicate, right? And when you plug into those systems, you can qualify the time, you automatically qualify for the reimbursement if the patients are consented, et cetera. But knowing when is the key difference between succeeding with a CCM RPM program and not succeeding with one. It makes all the difference. Healthcare is communication.
Got it. So we do have some great questions here. Thank you very much, Matt and Jess and Carrie. So why don't we jump into some questions? I think they're applicable to a lot of people on the line. So maybe we just do like 30 seconds per answer or so, and we can run right through them. Some of these are right in your wheelhouse, Matt. And as we get them queued up, Carrie and Jess, I'll actually let you guys ask the questions and maybe we can answer them. But I'm also, when I was asked to do this webinar, I just kind of smiled ear to ear because I've been a very happy Spruce customer for about 6 years now with my DPC doctor. So I've been using the platform. So when I was asked to do this, I was elated because I'm a very big advocate for the platform. And also I've known Matt for many, many years, and to know the product, they're fully integrated, brings tremendous value. So I was honored to be here today. So thank you for that.
Nice. You guys covered a lot of great content. Thank you for that. We do have some good questions that have come in. I think, Jess, we can probably tag team some of these. I'll just start at the top because Harold asked this question right out of the gate. Can a podiatrist provide and bill PCM?
No.
Okay. Thank you for that. Okay.
All right. So some people are asking questions about you connect with EHRs. Is there some like really easy ones that if you have this EHR, we're automatically going to be able to get the data, or is it case by case, or
Like
is it
Athena? Yeah, the Athena, Epic, those are the big ones, are great for us. I think Elation was in there, Matt. Can you guys do Elation?
There's Tebra, ECW,
Athena.
Yeah, for interfaces, I mean, next gen, yes, we can interface with anyone. There's several that are already turnkey. With Athena, with Tebra, with the ECW, it's as simple as pressing a button. Some of the others take a little longer.
We can do CCIQ, can do Epic as well. Obviously, Epic, everybody knows, takes a little bit longer. But next gen, yeah,
and I think
the major ones.
We already have an integration with Elation, so that's why we heard that question. So, and I think last time I talked with you guys were working on that, and you work at that. So I encourage anybody that does want to know if their specific EHR would work, or what's it look like, to go to CCIQ's or ChronicCareIQ.com, and you can message them, and they'll be able to give you more details on your specific EHR, because as we know, there's a few.
Yeah, and Jess, actually, I know Chronic Care and the team there built a specific page too. It's ChronicCareIQ.com/Spruce. Has its own page customized just for Spruce and Spruce customers and Spruce prospects. And there's a great video out there that was just launched today, talking about the integration, talking about the mutual success. So feel free to check that out. It's ChronicCareIQ.com/Spruce.
All right, I have another question here. So you guys talked about some really big organizations. You talked about a 2-provider organization. So it sounds like it doesn't matter if you're a small private practice or a larger 5-10 provider practice. Anyone could use these and use your services to help them get reimbursed. Is that correct?
Yeah, that's correct. Right.
Okay.
So, and the vast majority of our customers are practices under 10.
Great. And that's similar to Spruce. So it's a perfect little marriage there.
Yeah. I admire those folks that are putting that out there every day, because I know how hard it is. So that's where my heart is.
All right, Carol, which one did you have queued up?
Well, I was looking at Sarah's question with respect to communication with an aging community. I mean, I can let Jess answer this one because we have incredible success using Spruce across generations. And in fact, caregivers have played a pretty pivotal role in Spruce and communication. Jess, do you want to hit that one?
Yeah, so with Spruce, we've been seeing more and more collaborations between, elder care or pediatrics, all of these things, or like a child that needs help with their diabetic care, or adult that does, right? Mm-hmm. So in Spruce, we offer group texting through our secure messaging. So that's one way we do it. You can also associate different conversations to different family members. Justin, Matt, what are you guys seeing when it comes to how do people get reimbursed for talking to the caregiver? Tell me about that briefly.
So, yeah, the reimbursement is for the time spent by the doctor and their staff. So the time that it takes a patient, in our case, to answer their questions, or when they're texting back, doesn't count. But when you're texting them, that
Right.
time crafting that text counts.
Even if it's to the parent or the child of the actual patient.
Yeah. Oh, sure.
Absolutely.
Sure.
Care
Absolutely.
coordination. You got it.
Yeah. And
All
it's,
right. Also, I want to remind everyone this will be recorded, and we will be sending out links to what we're talking about and to get a hold of everybody on the call. So that will be coming soon. All right, Kara, did you see another one that you thought was, or Justin?
Let's see. Well, so let's see.
I'll do John's.
What's that?
There's one with Matt. I can do Matt's after that.
Okay, go for
Yeah.
it, Justin.
Well, yeah, just integration through HL7. So we try to use the Fire API where we can. So like Athena and others use Fire in the API. So we would specifically use whatever the vendor can promote and what the EHR company can support. So we prefer API, our integration with Spruce's API. So it all really depends on what that company can work with us. We prefer the API, but we can do HL7 route if we have to. Sometimes if it's an older technology we have to use or certain data has to come through HL7 specifically, but we'll use API when we can.
All right, I have a question here. So it's just more to remind people. So if you're a counselor or a therapist, you can reach out to CCIQ and they can help you. So you don't need to go to a specific company for behavioral health. You can ask them. So that one's good. The other one, and I just don't know this answer. So are you finding providers that have CPT codes on their existing fee schedules with payers, or do you need to request they be added?
all these CPT codes are already there with payers. What you will want to do is if you have, let's say in Alabama, for example, Blue Cross owns almost all the Advantage plans. So if you have a healthy population of a specific Advantage plan, you might want to ask them, say, and we're happy to provide you the codes, right? That are like, which of these do you reimburse for? Blue Cross made an announcement a couple of years ago. Across the board, nationally, they were paying for RPM. So if you had 20 minutes of non-face-to-face time devoted to a patient, and it was a Blue Cross patient, we wouldn't even try to build CCM, even though it pays more. We would push it directly to RPM so that you wouldn't get a denial. Did that answer your question?
Let's hope so. And then if not, they can write back in. It wasn't directly for me.
There was one that, Jess, you had sort of touched on earlier, but with respect to sending pictures through CCIQ, is that A, possible, and B, part of what you can get reimbursed for?
Yeah, so there's a couple different kinds of reimbursements for getting a picture. There's a store and forward reimbursement that is based on the amount of, not the amount of time, but reviewing the image. That is done through Spruce, right? So that time actually has to manually be added if you're not billing it as an event, as a check-in. We can help you with that.
Okay.
There's a drop down where you would select image and it would bill the time on the image if you didn't bill it as a virtual check-in or store and forward code.
Okay.
But the time you spend looking at that image and sharing it with other providers counts as care management time.
Okay, I have a good question I saw because I don't know this answer and I love those. So do clients accrue any additional costs? I think I know the answer. Do clients or, the patients accrue any costs from copays for billing insurance for these new codes?
Yes, they are standard Medicare copays. So,
right, but they're not additional. This is stuff that they're already paying copays for. The patients don't get additional charges.
There's no additional
for
fees,
these services. You're just doing them for, providers are just doing these services essentially almost for free sometimes. And so then
they get paid.
Yeah. So
we have no per patient charges. Right. We don't charge patients anything. And that would be odd, I think, because the doctors do get paid very well for performing this service for Medicare.
Yeah. Okay. Carrie, did we want to just wrap up and see if there's any other comments?
Yeah, we just have a couple of minutes left. I will say Anna just asked a question for Justin and Matt. how do you conduct the analysis for the entire patient population? For example, non-Medicare or Medicaid plans?
Oh, so great with the analysis. And I'm guessing that you're looking at our website at the very bottom. Somebody can put in their provider ID number and see their patient panel mimicked in our platform and what their reimbursement would be. You can all go there and look at that. We cannot. We can only judge it based on the Medicare panel because that's the only platform that that's the only payer that publicizes their data. So we base it on the Medicare population.
Okay, that's interesting. You guys covered so much incredible content. I feel like I know a whole lot about this now, and eyes wide open. We have a couple minutes left. Do you guys want to just leave any final thoughts with our group that's still hanging with us?
No, it's just a great opportunity. Thank you very much. I know it's complicated, but hopefully we'll be able to, clear the air a little bit on it, and feel free to reach out to me with any specific policy questions, but also, Matt and the Chronic Care IQ team, if they can help in any way. And obviously Spruce, I mean, it's a great partnership and you guys are wonderful. And thank you for this opportunity today.
Awesome. Well, you guys were terrific. Thank you so much for joining us. And Jess, thank you for always leading the charge from the Spruce side of the house. This was a great session, and I will be sending out the link to this recording later today. So stay tuned for that if you want to revisit anything that we covered.
And we did give Justin and Matt's information. If you need to get a hold of Spruce, you can, if you're a current customer, you can always message into Team Spruce and we can give you any of this information. As well, you can get a hold of me at sales@sprucehealth.com. As well, you can also go start a free trial at sprucehealth.com and learn more.
Love it. All right. Thanks, everyone. Have a great rest of your day.
Thanks, everyone.
Thank you.
Bye.
Bye.